Hi, so hope everything's going well with your first weeks of class. And if you have any questions about D2L or anything with the online course, please let me know. Please email me and I will do my best to help you be successful. So this week we're going to have two different video lectures. The first one is going to be on the assessment process. And that's also what you're going to be using for your projects. Now, the second lecture will actually begin discussing some diagnoses and talking a little bit about that as well. So let's talk about the assessment process. And this, if you're able to see my screen here, this is what your content should look like for the second week. And I'm going to add in one more little lecture right there, or maybe down here with ADD. But there'll be a second lecture here. That'll be the only difference. But let's look at notes, contents of a good record. And you will see that right here. And this is just a one-page list. What goes into a good record. And in the clinical mental health counseling field, a lot of this will be online now. However, I would say over 50% still have paper records, files. Within that file, there will be multiple cardboard sections. As you page through it, you'll have some type of identifying data for your client, any type of informed consents. Now, that's just a consent that you have the client's permission to talk with or contact someone or an agency or a doctor or something like that. Whenever I do an initial assessment with a client, that's one of the first things I do. So, you walk in and you introduce yourself with the client, and then you go through what confidentiality is and the limits of confidentiality. I usually have them sign some type of form that says that we reviewed that and they agree to it. And what those limits of confidentiality are, just so that I have that documented. And then, as we talk, if they mention a medical doctor or a psychiatrist or another agency that they've been to, anybody that I might need to contact to get more information, we fill out a consent form together, and I tell them why I might need to contact those individuals. Anything that might need to be transferred, like medical records or files from another agency or something like that. Inpatient to outpatient, outpatient to inpatient. Any types of treatment plans and contracts should be in a written form. And then, of course, the diagnostic assessment interview, and we're going to go into that in a little more depth. The client's history, anything that is pertinent. I usually do a suicide assessment to have that on record. Of course, if they are a danger to themselves or anybody else, we need to move in a different direction and contact the appropriate people to get them the help that they need. But I do want to have that suicide assessment on record Sometimes I even do a mental status exam, but we'll talk about that later in the course. And then any notes of my therapy sessions. So there's always a debate about notes. Some people say that, it's detrimental to keep detailed notes, and they keep them as short as possible. Other people go into great detail and outline their thought processes and whatnot. So here's the answer to what makes a good note. I want you to imagine that either the client is able to see your notes and they can request them, or a lawyer subpoenas your notes for court. So when you write a note, imagine either the client reading them or a court hearing them. That means you're only going to write professional notes. You're going to write them in professional language. You're not going to write things like "I believe." You're going to write observable facts, things that the client shared with you, anything that has to do with the diagnosis based on criteria. You're going to write up treatment plans. You're going to talk about progress, things like that. It's very factual. You are going to go into some detail. If you do not go into detail and the records get subpoenaed, or if you get sued for any reason, it is better to have detailed notes than sparse notes. So I always tried to keep good notes. The other thing about notes is there are so many considerations as far as security for notes. If they are paper notes, they should be in a locked cabinet or drawer. Only certain people should have the key to that. They should be also behind 2 locked doors, so they should be in a special room where not everybody has access, and the building should be locked. So that is 3 levels of security. Electronics are a whole other story. So just imagine if you're using an electronic app to keep notes, either on a computer, a tablet, or even a phone, or if you've discussed a client in email or anything electronic like that. If you use anything, computer, tablet, phone, you really have to have multiple levels of security as well. So you should have a password for the app itself, and you should not save the password so that it opens automatically when you press the app. You should have to type it in every single time, or use facial recognition or a fingerprint in order to fill in the blank for the password. It should not go automatically into it when you open it up. You should also have a password to get into that device, and it should not open automatically without that password or facial recognition or fingerprint. Ultimately, you should never take records out of the office, out of that, I'm going to do these at home. No, what if somebody steals your car or your backpack or briefcase or anything like that? So multiple levels of security for those notes. And there are all kinds of regulations for that as well. Psychiatric evaluations, current medications being used, diagnoses. With the medications, I always ask the client to bring in whatever medications they are using. And that way, I'm thinking about, I can get the exact milligrams, the exact name, whether it's a generic name, how often they take it, things like that. A lot of times clients are not sure of exactly the name or milligrams of the medication, so I just have them bring them in a bag. Here's an interesting thing about medications. A lot of clients do not consider medications that are over the counter as medicine. Let me give you a quick story about that. I had a client that was a child, and the mother came in, and I noticed that the mother was looking a little depressed and down and also tired, and asked her how things were going, and we began to talk, and she told me that she was experiencing some liver and kidney failure, and they couldn't figure out what was going on. And so I asked her, well, what does your normal day look like? And she says, well, she experienced some loss, she's also having some emotional problems, and she sleeps most of the day. Well, I said, well, then what happens at night if you sleep all day? She says, well, she sleeps all night too. And I said, well, that's difficult to do day after day. Are you taking any kind of medication or using any type of substance? And she said that she was taking Tylenol PM and taking it many times a day, like 4 times a day. Well, people don't realize that Tylenol is one of the most dangerous drugs on the market. It can cause liver and kidney failure, toxicity. But she was taking it because it was mixed with Benadryl, diphenhydramine. So, I think a lot of times people don't realize the impacts that these things are having, physically and emotionally. And I don't only focus on medications that are psychological. I want to know about all of the medications because many medications have side effects. They can cause drowsiness, depression, anxiety, nervousness, increased or decreased heart rate. So many. And a lot of times individuals will get medications from different doctors, and those doctors do not communicate with each other. So sometimes it's the combination of medicines that could be causing the psychological or emotional issue. So a lot of medications for the elderly, for example. I think that there are just so many different medications on the market. Or maybe somebody's taking a medication for a physical problem, and then they're going to see a psychiatrist for a medication for an emotional problem, and those two medications have some kind of interaction. So it's really important to pay attention to all of the medications. There are a lot of resources online that you can look up and see what interactions occur between medications as well. Now, don't claim that you're a medical doctor or an expert on medication, but you can refer them to a medical doctor, or you can go back and you can get an informed consent form and discuss what they're experiencing emotionally with their physician, and discuss any possibilities of medicine and interactions. After you move through the entire assessment process, it used to be that a doctoral level individual would be the one to make a diagnosis, but that is no longer the case. Many times master's level individuals tend to make diagnoses, and they are supervised by a doctoral level individual. Now, my thing with diagnoses, so many people get a client and they look at the diagnosis if they've already received one, and they allow that to influence their thinking. I do not look at previous diagnoses before I make a diagnosis. I do my own assessment, then make my own diagnosis, and then I review the charts to see if there's anything that I missed, to see what the previous diagnoses were, to see if I missed any symptomology or criteria, if there's any history that the client did not disclose or share with me that I need to consider in the diagnostic process or in making a differential diagnosis. And a differential diagnosis is narrowing down the type of diagnosis that, so for instance, there might be multiple kinds of bipolar. Well, which one is it? Well, you have to use a differential criteria. Well, they meet this criteria, but not this criteria. And we'll be talking about that in more detail. So, I've just run across so many incorrect diagnoses that, and the problem with an incorrect diagnosis is that it often leads to incorrect medication that could have more detrimental effects on the individual client. So it's actually doing some extreme harm. So let's go through the rest of this list. We'll talk about the effects of diagnoses before we move on to the next one. So we have consultations with other therapists, all correspondence and notes. If we make a phone call, we have to make a record of that phone call and what was discussed, when it was placed, who we talked to. Notes of all failed or canceled appointments, document any supervision, and what happened during that supervision, what was recommended, what's the prognosis? Well, how, do we feel as though that treatment plan will be successful? What are the odds? Any terminations, financial records, and any casual contacts. So that is the contents of a basic record. But before we move on, let's just talk about how important a diagnosis is. It could have a major impact on an individual's life. It could really help them, or if it's inaccurate, it could really harm them. So if you're wondering about anything, I would definitely get a treatment team's opinion and a supervisor's opinion rather than just running with a diagnosis. You don't want to begin doing this on your own until you're really secure in it. Okay, so let's look at RX scribbles. This is just a handy little reference sheet that I think is that's a Freudian slip, often helpful for you. And it just tells you what all of those abbreviations are on medication bottles. Okay, so let's look at an assessment. This is an actual assessment from a place that I used to work called Adams Hanover Counseling. That was in Gettysburg, Pennsylvania. And this is a template that I used to use. It shows exactly the order of the different things we discussed in their charts. Now, when we do an assessment, a lot of times therapists will just ask the question and write down the answer. But I want to build trust with the client. I want to have a more conversational discussion with the client. And I want to add depth if I feel as though something is important. So I want to follow up on any type of question or answer. So, the presenting problem. Why did the client come into therapy? Well, sometimes that is the underlying issue. Sometimes it's not. Sometimes it's just a symptom of a deeper issue. So, we write about, well, okay, what's the reason they're there? Why did they come in the client's own words? And I use quotation marks. They might be experiencing depression, sleep, eating, mood disorders, memory problems, problem with enjoyment. I want to make sure that I cover the suicidal ideation. And do they have any thoughts of hurting themselves, harming themselves or others? I want to document any gestures made. Have they had any previous suicidal ideation or attempts? How were they made? Do they have a plan? Things like that. All of that I take care of at the beginning of the session. Do they have any strange or abnormal, in their mind, mental experiences, hallucinations, messages from God, things like that? So I want to rule out some of those larger areas. So what's the history of their present problems? Has this been going on for an extremely long time? How long have they had this problem? Maybe this is one symptom, but it's appeared in other ways throughout their lives. How long has this whole thing been going on? Do they know what triggered it or initiated it? Do they know how it began? Can they remember that? Was there a difference before they experienced this and after they experienced this? Has it gotten increasingly worse or better over time? And once again, I want to have a dialogue, a conversation with them, so that this is really more detailed. I want to get some depth with this. What's their social and family background? And in the back of my mind, I'm always thinking of different domains. They have a physical domain. They have a career and academic domain. And they have social, emotional, and relationships. They have family of origin and their past relationship and present relationship with that family. They have a current family, perhaps, or maybe they're living alone. Do they have a significant other? Have they had multiple relationships? Have they never had a relationship? What about friendships? Are they social? Do they have friends, a friend group? Or do they have long-term friends or short-term friends? Things like that. Who they talk to when things get bad or when they're feeling depressed. I try to get names of family members or school members and assigned release if I need to talk with them. If the client tells me that, comes in and they say, oh, they're feeling suicidal, and I have a signed release that I can talk to somebody and share information with them. Now, I don't just call them and not let the client know. I say, well, I'm concerned about you. I want to make sure that you're safe. Would you mind us contacting someone? Involvement in social activities or interests. What do you do when you're not at school or work? What do you like to do? Do you have any hobbies? Do you like any kinds of music? Sometimes it's good talking about music with clients. Have them bring in some music or lyrics that have meant something to them. Medical history of families. I made a mistake here. Medical and psychiatrics. I just mixed those up. Have family members ever had emotional problems? So is there a genetic tendency to this? Have family members or relatives suffered from cancer, high blood pressure, diabetes, heart disease, any other major illnesses? Was it maternal or paternal, so mom or dad? Current or past legal problems. Have you ever been arrested? Are there any pending legal problems at this time? It not only tells me about the client, but it also gives me a hint on whether they want me to go to court or not. And I have to consider that. How about their past personal history? Try to fill in any gaps, tie any information together. Numbers in family and places according to name, sex, age. Who do you feel closest to emotionally? Who was the authority figure? Were they a disciplinarian? Is the family together? When did it split? How old were you? How about current family? What's your strongest memory of childhood? Was that positive or negative? How did it make you feel? How did you feel about it? Nothing makes somebody feel something. But major problems or traumas, past or present. How did they do in school? How are they doing in school? How old were you when you started to date? What was your first serious relationship? What was that like for you? How old were you when you first became sexually active? Kids and birth control, that is up to the agency usually. The agency I was at wanted me to ask about that if they were over a certain age. But some agencies do not want you to talk about that. So if divorced, why? If still married, happy, not happy? Try not to ask leading questions. Try to ask open-ended questions. So, for example, if you're still married, how do you feel about your marriage? That's an open-ended question. I always ask with each of these categories, is there anything else that I might need to know that I didn't ask you? Is there anything else that you think is important that I might need to know so that I can better help you? Current medications, physicians, treatments, illnesses, early development, any hospitalizations or surgeries, ever admitted to a hospital, any serious medical problems, any history of abuse, any physical problems, drugs or alcohol. How old were you when you, whatever, began using? Has there been a period of heavy use? Do you have a drug of choice? What's your current use? Have you ever been admitted to a counseling treatment center or hospital? Try to get a release signed for that. Have you ever been in counseling before? With who? What was that for? Try not to ask why. Just brings people to the cognitive level rather than, so I usually say, what was that for? What brought you there? Were you released? Was it stopped? Okay. I get some educational information. I ask things like any favorite teachers, any problems, least favorite subject, favorite, any special training or job skills, current occupation, how are they doing financially, do they have stressors, what did you like best about your job, why did you leave if they left. I usually do not fill out personal impressions. I don't like impressions. They are, what's the word? I like observable facts rather than personal impressions. Okay, so we've gotten down to the diagnostic criteria. Now, you need to learn both the old way of doing it, up until the DSM-4TR, and the new way. And the new way is simple. You simply write down the code of the diagnosis and the title of the diagnosis, and if there are any subcategories, you write that down, and you can write down the severity, mild, moderate, severe. So there are no axes for the current mode of writing down diagnoses, but there used to be. So it's important that you understand those as well. And I think if you have any clients that have been in the system for a while, you'll probably get some old diagnoses. Okay, so doesn't matter whether it's 3R or 4TR, all the axes have been the same for a long time. So, axis 1, that includes clinical syndromes and V codes. And those are just sections of the DSM. Axis 2, any developmental disorders or personality disorders. Axis 3, physical disorders and conditions. Axis 4, severity of psychosocial stressors. Have they experienced a loss? Did they lose someone they loved? Grief and loss? Did they lose a job? Are they struggling financially? Did they go through a divorce? And the current GAF, which stands for Global Assessment of Functioning. So this became problematic over the years, and now they just keep it to specific diagnoses or comorbid diagnoses. But you do need to understand, Now, the global assessment of functioning was the worst part, and I'll give you an example of why. Okay, so if somebody says, oh, well, they're 50, okay, well, that could be anything from serious symptoms like suicidal ideation or no friends. Well, that's a big difference. So, I always took this with a grain of salt. I never really relied on it too much. It was just not helpful. Everybody would fill it out differently. This is a very basic treatment plan, just an example. This is an example of an authorization to release or obtain information and how to fill it out. And that is it for the assessment plan. you can use that as a guideline for part of your assessment for your assignment. But you're also going to have to look up treatment and talk about the criteria of the diagnoses, which we'll go over as well. But that would be the first part, the assessment, and then you make a diagnosis. But in order to make a diagnosis, you have to discuss each of the criteria. How does the client fit each criteria? And then you're going to end with a detailed treatment plan based on some studies and therapy. I know that's a lot. So the last thing I wanted to show you briefly here was the IEP. And I know that this is sideways on your screen, but I just wanted to give you an example, and this is what they use in school systems. And so it's an individual education plan, and teachers, counselors, people who work with disabilities, English as a second language, all kinds of individuals might be on this team. And this is just an example. You would work on this with the parents and the teachers and those other individual professionals to talk about how you could help that student succeed on an emotional level. So if they're experiencing anxiety or anything like that, how can you help them within the school setting if that's your assignment? Okay, so that is a basic overview of an assessment.